A warm welcome to the virtual conference on oncology cancer treatment update 2025. Uh, would like to invite Mr. Prasad Vasanti for their talk. Over to you, Mr. Prasad.
Good evening. I hope I'm audible. Is my screen visible? And please confirm if it is moving.
Yes, sir, it's visible. Can you please make it full screen?
Yeah, sure. Is it okay now?
Yes, sir, please continue.
Yeah. So, very good evening, all. So, to set the context, I'll be speaking on overview, mostly focusing on the recent changes in management trends and the changes in the evaluation of the patient of suspected lung cancer. So, this here represents this pie chart represents the burden of uh, lung cancer. As per Globocan data, it was 2020. So, however, we have recent NCRP estimates of 2022, where lung cancer constitutes the first among these top five cancers, among mouth, prostate, tongue, and stomach. And in females, it is one of the top fifth uh, malignancies. And even in when compared even in the both the sexes, it constitutes one of the cancers which is contributing uh, highest case burden among the top five. So the changes in AJCC seventh edition and eighth edition, these in the eighth edition as compared to seventh edition staging, TNM staging, there is more focus on subdivision of early stage tumors, like T1A is less than 1 centimeter. However, it was less than 2 centimeter in AJCC seventh edition. And also, the uh, T3 lesion, 5 to 7 centimeters in AJCC 8th edition, which was earlier more than 7 centimeter in AJCC 7th edition. So there is also change in the classification of metastatic lesion. M1C has been added to denote multiple extrathoracic lesions. Uh, so routine investigations for staging include bronchoscopy, CECT, PET-CT, EBUS, endoscopic ultrasonography, mediastinoscopy, and MRI brain. So what is the difference or what is the concordance between CECT, PET-CT for staging in NSCLC? So for lesions, for lymph nodal lesion, more than 10 mm dimension in the short axis is considered uh, highly suspicious for malignancy. And the role of CECT is limited. Only CECT scan is limited because of low sensitivity and low specificity. Hence, addition of PET to the CT improves overall sensitivity and specificity. So, what are the risk factors for a patient to harbor occult N2 disease, occult N2 state disease? So, as we can see here in this retrospective analysis, so in the surgical specimens, as the size of tumor increases, the possibility of harboring occult N2 metastasis also increases. In a patient with the tumor size of more than 6 centimeter, there is almost 50% chance that there may be occult N2 metastasis. And other factors to be looked at is the location of primary and the size of the tumor, and based on the SUV also. So high SUV might also correlate with the presence of occult N2 metastasis and central tumors. So to detect occult endometastasis, what are the staging approaches? So there are less invasive approaches like EBUS and endoscopic ultrasonography, and more invasive approaches like mediastinoscopy, which can be conventional or video assisted mediastinal lymphadenectomy or VATS. So routinely EBUS is recommended because it is less invasive. And if there is clinical suspicion of N2 involvement, uh, even after negative EBUS, surgical staging with the mediastinoscopy is recommended. So for centrally located tumors and tumors more than 3 centimeter, and for patients with extensive infiltration of mediastinum without extrathoracic disease or positive N1, and patients who harbor bulky N2 on CT scan might not undergo invasive confirmation. However, patients with discrete N2 disease may require mediastinal staging by EBUS or mediastinoscopy, regardless of the PET result, to know the involvement of, to know whether it is a single station or multi-station N2 involvement. So this, as per this algorithm, patients with negative mediastinal lymph nodes, clinically N1 or N0, with high risk of possible occult N2 involvement should undergo EBUS and endoultrasonography. And if the mediastinal lymph nodes are positive, should undergo multimodal treatment. If the mediastinal lymph nodes are negative, may be considered for surgical or radical radiotherapy, surgical therapy or radical radiotherapy. For those patients who have positive mediastinal lymph nodes in PET-CT, or if it is a bulky lymph node, there is no need to confirm by uh, mediastinal staging. If it is a non-bulky, as discussed earlier, patients will require mediastinal staging to know whether it is a single station or multi-station involvement to decide on surgical versus radiotherapy. So this is the uh, chart showing the accessibility of various lymph node stations by various procedures. Like as we can see here, the surgical approaches have highest accessibility, and the accessibility with the EBUS is also comparable with the surgical approaches. So coming to the evolution of uh, NSCLC as a disease. So earlier, as we can see, the evolution through various phases of subclassifications like small cell lung carcinoma to non-small cell lung carcinoma, and then histological breakdown, then the molecular classification based on the driver mutation. And at present, along with the changing paradigm in the therapeutic approaches, there is also subdivision based on the tumor mutational burden and PDL1 expression. So what are the advances in management? So as we can see in the graph here, so the trend of incidence and incidence-based mortality uh, in both males and females, it has been in the declining trend after the approval of EGF targeted therapy especially. So what are the other advances in early and late stage lung cancer management? So mainly over the last couple of years, it is the addition of immunotherapy even in non-metastatic disease, that is either as neoadjuvant or adjuvant or a perioperative approach. What are the current guidelines? So as per stage-based management, in patient with stage 1 disease and stage 1A, there, there is no observed proven benefit of neoadjuvant or adjuvant chemotherapy. However, stage 1B and beyond, multidisciplinary approach is suggested, and stage 2B, stage 3A, stage 3B, there are various approaches which can be formulated, like adjuvant chemotherapy or neoadjuvant chemotherapy or sequential chemotherapy with radiotherapy. So the management is also based on the potential resection outcomes. So all the uh, immunotherapy trials have looked at the response to pre-operative or neoadjuvant immunotherapy in the form of uh, pathological complete response or major pathological response MPR or PAT-CR to develop a treatment escalation or treatment de-escalation protocol. So what are the what is the risk of recurrence in a patient with resectable NSCLC? So it is seen that after surgery and chemotherapy with or without radiotherapy, almost around 50% of the patients recur. So this has led to the development of multimodality approach, mostly in incorporation of adjuvant chemotherapy, and at present the incorporation of immunotherapy. So this was also supported by LACE meta-analysis. And so coming to the ADORA trial, which showed improved DFS in osimertinib in resected EGFR mutant NSCLC, we can see the difference between the placebo arm and osimertinib arm, and the DFS improved from 44% in placebo to 90% in osimertinib arm in 22 years. And also the atezolizumab uh, in patients with in adjuvant setting in patients with more than 1% of PDL1 positive staining. So what are the changes, or what are the developments in radiation therapy in lung cancer management? So intensity modulated radiation therapy, it has shown to improve the survival of patients with stage 3 NSCLC T3 T4 diseases, by also by reducing the exposure to organs at risk, and also adequate dose distribution to the primary, and also the development of stereotactic body radiation and IMRT. So other improvements include 4D CT planning, IGRT, adaptive radiation. So these checkpoint inhibitors are moving to the early stage in resectable and resectable lung cancers, stage 1B to stage 3. So prior to the incorporation of checkpoint inhibitors in resectable lung cancers, there is a notable trial, a Pacific trial, where the checkpoint inhibitors were given as maintenance therapy in unresectable cases, and which showed improved overall survival at 5 years of 42, roughly around 43% in comparison to the historical overall survival in unresectable stage 3 cancers. So what are the emerging treatment paradigms which we have already highlighted? The incorporation of targeted therapy and incorporation of immunotherapy in the resectable setting. And I'm sure the uh, further discussion about these newer modalities of therapy incorporation will be done in the upcoming discussions. So this is a pictorial representation of survival outcomes with targeted therapy in advanced NSCLC with various treatment modalities like platinum doublet, or we can see around 4 to 8 months with platinum doublets, 6 to 12 months in non-squamous and squamous, around 14 months. Incorporation of targeted therapy, osimertinib, up to around 39 months with FLORA, and ALK inhibitors extending beyond 35 months with the earlier generation, and we all know lorlatinib, the current third generation, has not reached overall survival benefit even after 65 months of observation, and uh, RET NTRK ROS1 and BRAF Metexon 14. So all these targeted therapies have shown to have a significant survival benefit in the form of, mostly in the form of progression-free survival. So, so approvals of ICIs over time, earlier approvals for in the metastatic setting in 2000 from 2015 to 16, pembrolizumab and atezolizumab, and later moving on to the unresectable setting, stage 3 disease following concurrent RT, Pacific trial, durvalumab, and now coming in the resectable setting, either as adjuvant therapy and neoadjuvant therapy or perioperative therapy. So I'm sure the details of each trial will be discussed in the upcoming discussions. So now coming to the role of antibody drug conjugates. So, so antibody drug conjugates are mostly in the only at present in the advanced setting. Trastuzumab deruxtecan in HER2 expressing advanced NSCLCs, and CAR T cell therapy. So what are the key takeaways of this discussion? That I'd like to highlight the landscape of management of lung cancers. Resectable, even the resectable setting has drastically changed over the last couple of years, and newer therapies have also shown some overall benefit with various subtypes of molecular alterations. So hopefully this DFS benefit will translate to OS benefit, and will lead to better quality of life and better survival outcomes in patients. So thank you. I hand over to the moderators.
Thank you, Dr. Prashant.
Thank
Sir.
So it was a good presentation and with crisp overall presentation of lung cancer overview. So yes, you have already told that we are going to discuss regarding further trials and further recent advances in upcoming lectures. And second lecture we will move forward to, and topic was regarding biomarkers and how we should do biopsy and how we should proceed for, and what is the role of liquid biopsy. This topic is supposed to be taken by Dr. Bhushan, but he is busy in duty. So I'm going to take on behalf of him. So let me share my slide. So my slides are visible.
Yes, sir, it is.
Okay. So I will talk about what is the role of biomarkers testing, molecular biomarker testing in lung cancer. As we all know that term personalized medicine and targeted therapies and immunotherapy all have come through this area of oncology, lung cancer only. So these are the subheadings, and I'm going to discuss about this presentation regard in these headings. Like first of all, we will discuss about the epidemiology of the lung cancer, why we are discussing this cancer, what is the unmet need, why we need more advancement in the management of this cancer, because of the although many research have been done in this pathology, but still there is a whole lot of to be done because of still a significant mortality. And to improve that, what is the role of biomarker testing in NSLC, how this has evolved, what is the past, and now what we are going ahead, and what is the future, and some key takeaway. So according to Globocon 2020, if we see number of new cases, if we see in all sexes, it is fourth in number. It is 72,510 new cases in 2020. And especially if we talk about the males, in males, this incidence increases further, and this is second in number in incidence wise. Out of 72,510 cases, 51,675 cases were in males only. So second most common cause of cancer in males is the lung cancer. So overall new cases, these 72,510 fourth in rank if we see all sex, and in males it is second. Mortality wise, out of 72,000, not all these of like overall, and in a year, because of the lung cancer, 66,279 are the mortality per year, and 5-year prevalence rate is around 80,000. So this is a huge number overall globally. So it is a very common malignancy, and incidence is increasing day by day. It's not of the malignancy of developed country only. It is increasing in developing country like India also. And main etiology is tobacco, smoking, and nowadays pollution is also playing a big role, although not identified in studies, but it is a major concern. Otherwise, some form of family history, and so main etiology is tobacco. And so otherwise, if we see evolution, so initially conventionally lung cancer patients were being treated according to histopathology, but then it was got to know that there are some driver mutation like EGFR and ALK, and later a whole lot of different type of driver mutation have been identified in the lung cancer patients, especially in the non-small cell lung cancers. So 50% of the patient with advanced non-squamous NSCLC, they have either of these EGFR driver mutation, which are targetable with a FDA approved agent, and or there may be some ongoing trials regarding these mutations and treatment. Most common mutation, as we all know, is EGFR's mutation, EGFR sensitizing mutation. That is in the tune of 17 to 20%, and it is even more in the Asian population, up to 25 to 30%. Other second most common mutation is ALK. These are the targetable. We have drug for these EGFR and ALK. Although numerically most common mutation is KRAS. So trials are going on for KRAS targeting treatment in the form of sotorasib and aggressive, but these are not approved drugs. We will see in the future about these drugs also, and what is the effect and all. But at present, approved drug are EGFR sensitizing drug, that is first, second, and third generation TKI for EGFR mutation, gefitinib, erlotinib, afatinib, osimertinib, and dacomatinib. For ALK also we have 3 generation TKI, crizotinib, then alectinib, ceritinib, and then lorlatinib and brigatinib. And otherwise, other mutations, if I enumerate here, are MET, HER2/neu, ROS1, BRAF, RET, NTRK, PIK3CA, MEK. So maybe in 1 or 2%, but if we combine all these, so these are also a significant number of patients in which some form of driver mutation, for which we can use some form of targeted therapy like capmatinib for MET inhibition, TDXD for HER2/neu, crizotinib for ROS1, and entrectinib also, dabrafenib for BRAF, and this sulpercatinib for RET fusion, for NTRK entrectinib. So all these drugs we can use for these patients. So overall, more than around 50% patient we can treat with some form of targeted therapy. So importance of biomarker testing in non-small cell lung cancer is obviously it is a field where this concept comes, and nowadays with the extrapolation of that, in each and every solid malignancy we order NGS. We do some form of solid panel NGS and try to check for these driver mutations, because these are not exclusive for lung cancer only. Obviously, these may be found in any solid malignancies, and accordingly we can treat those other type of no, beyond the lung cancer also with these TKIs. But studies have shown that patients with identified actionable mutations, if they receive appropriate targeted therapy, they have very improved outcome. And we all have seen this in our clinics. If, even in patient, if patient in the ICU is almost PS of 4, 4.5, and we know that patient is not a candidate for chemo or even for immuno. But if by that patient's fortune, if any of these driver mutation we can found and we can give that TKI, then those patients within a span of maybe few weeks can be survived, and maybe clinically significant improvement in the PS and responses. And we have seen some of those type of patients who survive even more than 2 years, 3 years. So it is very, very relevant and clinically important discovery. And so guideline recommend routine biomarker testing to guide treatment decision in each and every advanced NSCLC patient as at least. So barring ASCO, NCCN, ESMO, CAP, all guidelines say that at least we have to check EGFR, ALK, ROS mutation, and PD-L1 expression also. And according to ASCO, NCCN, other driver mutation like BRAF, MET, RET, NTRK, KRAS, all should be checked. So because we have seen that if we give appropriate targeted therapy for these mutations, obviously we can give, even if we check for that. If we don't check, we can't give. So those patients who may get benefit of that TKI may have been devoid of that benefit, and so that should not be the case. Now coming to next step, like how we should check for these mutations. What are the different methods for the tissue testing in SCLC patient? So first method is DNA sequencing, that is NGS or PCR. So by this NGS and PCR we can detect insertions, point mutations, deletions. So these by these we can detect aberration in EGFR, KRAS, BRAF, HER2, MET. So we can order single gene different NGS, so like single gene mutation testing for EGFR, single gene mutation for KRAS, or otherwise we can order full NGS panel, or in some laboratories we can plan important gene panel like smart lung NGS panel, as we do in our institution in RGCA. Other method is RNA sequencing panel. It detects fusion vulnerability also, and is more sensitive for ALK, ROS1, RET, and NTRK. So obviously, if we want quick results, and at least EGFR and ALK, that those are the most common one mutations. If we want within few like maybe 2-3 days, 3-4 days results of those, then we can order ISC or FISH, because FISH can detect ALK and ROS1. It is highly specialized, can be faster, and ISC can detect ALK ROS1. It is also very easy test and fast. And by ISC we can detect PD-L1 also. By PCR we can detect EGFR, that also we can get report within 4-5 days. And obviously because NGS will take at least 2 to 3 weeks, sometimes patient PS will not allow us to wait for those many days. So what is the evolution, how these biomarker testing was done in previously, and now what is the status? So if we see this journey, preliminary diagnosis we have to make by ISC and morphology only, because after that only we can go order for molecular test. It should because this is recommended for non-small cell, not in small cell. So what is the different biopsy method, how we can obtain specimen? So we can obtain specimen by resection, because nowadays these EGFR TKI have role in adjuvant setting also. So via resection or excision or small tissue biopsies we can get these tissues. If obviously every time it is not possible, and in lung cancer tissue is an issue, sometimes we have to manage with the poor fluid cytology cell block only, or some FNAC sample only. So these exfoliative cytology most of the time in these patients we get from pleural fluid, but sometimes sputum cytology, CSF cytology, ascitic fluid and urine cytology may be from where we have to do these diamutation testing. Otherwise, nowadays, recent advance in this area is that most of the centers now prefer liquid biopsy from blood via ctDNA, because many time patient refuse for the repeat biopsy. If we do tissue biopsy, then we have to prepare fresh frozen plasma, FFPE block, and then go ahead with the histology and cytology. And then after histology confirmation, we can go for DNA extraction and then assess via NGS or PCR or cancer gene panels or some specific target mutation. Via cytology also, FFP block or known cell block slide can be prepared, and same histology, cytology, and further assessment can be done. Via blood liquid biopsy also same. Here parallel diagnostic like ISC and FISH or ISC can also be done. So extraction is not only for DNA, we can extract RNA for RNA PCR testing, RNA NGS testing, and for protein also for proteomics. So obviously, if we see here for resection, excision, and all, surgeons, pathologists, interventional radiologists, all are important. For further steps, main is pathologist and laboratory staff. So histological subtype, whether squamous or non-squamous, this is the first step. We have to code that, we have to confirm that. At least it should not be small cell. For biomarker testing, primary tumor or metastatic lesions are equally suitable. It is not like that every time we have to do fresh biopsy. If obviously there is some time gap, there is some like last biopsy have been done maybe 6 months early, then if we thought that there may be some change in the cancer milieu in the micro environment, then we can order for fresh biopsy from metastatic lesion. But otherwise, it is almost same results if we do primary tumor sample or metastatic lesion. So bone biopsy can be suboptimal because of the decalcification and degradation of DNA. Liquid biopsies are another option if we don't have tissue for the biopsy or patient refuses. Then for testing of EGFR, AL, CROS1, BRAF, NTRK, RET, MET in all non-squamous NSCLC, it is the recommendation according to guideline, and we should use broad NGS testing to detect most of these mutations. There may be some other mutations we can pick, and that may not be targetable at present, but we should order still, because it may use as archival, and in future maybe further research can be done on those type of samples. For squamous NSCLC, we should consider this testing, not in all, but if patient is young, never or light smoker, or if biopsy specimen is of mixed histopathology, then we should order NGS in those patients also. Alongside, test for PD-L1 expression is also required, because we all know that if PD-L1 is more than 50%, then single agent monotherapy with immunotherapy. Otherwise, with combination of chemotherapy can be given even in the first line. But if PD-L1 is negative, then there is not much role of immunotherapy in that setting. For completion of testing within 10 to 14 working days, biopsy is recommended. Coming to ctDNA testing, it has a potential to apply across all stages of NSCLC and throughout the treatment pathway. It may confirm diagnosis, it may help in the treatment selection, it may monitor prognosis, response to treatment and progression or relapse of the disease, and via ctDNA testing, we may overcome some major challenges with the tissue testing. So, ctDNA genotyping is recommended for clinical use in advanced NSCLC to guide treatment selection under specific circumstances. Especially in resectable NSCLC, if we do ctDNA testing, although it is not a part of current clinical recommendation, but we may apply this in the setting in the future as a biomarker. ctDNA has several potential applications to predict or monitor clinical progression or recurrence. Obviously, radiologically, it may take time if patient is progressing. But if we want to monitor our treatment, we can order ctDNA. It is more sensitive. Minimally invasive method, if we do ctDNA, and because many times either like tissue is not possible to be taken, maybe it is in the bone, maybe in the deep in the lung, or many times patient refuses. So ctDNA in a bloodstream is comprised of DNA from all tumor sources in the body. It captures both tumor heterogeneity and tumor changes over time. So overall, if we can see with all these factors that ctDNA testing, although it may never replace tissue biopsy entirely, but it have a complementary role, very important, clinically significant role to support the treatment selection in patient with NSCLC. So it may be used to detect MRD also. I have told you that we can use this for monitoring purpose also. So if in advanced setting, initially PET scan shows a complete metabolic response, but still we all know that microscopically disease may be there. So to detect molecular like MRD, minimally residual disease after surgery in resectable NSCLC, we can do ctDNA testing. It could identify patient at risk of relapse and allow for the appropriate intervention. And the study name is TracerX study, in which 24 early stage NSCLC patient followed by longitudinally after resection, and then phylogenetically ctDNA profiling was done. So 93% of patients with disease recurrence were MRD positive, 90% patients without recurrence were MRD negative. So it is very correlating with the ctDNA finding. So after dissection, if we have done ctDNA, if ctDNA is negative, then most of the time those patients are not going to recur. But if ctDNA is positive, then most of the time those patients are going to be recur. So in the TracerX study, ctDNA profiling was able to confirm MRD if negative, and otherwise if detected MRD in patient who relapsed before their disease was picked up by the standard imaging. So it is obviously logical. So presence of MRD may be used to predict disease recurrence, and currently MRD cannot be identified using traditional diagnostic methods, but as detection of ctDNA in plasma, it indicates the presence of residual tumor tissue, and it can be used to measure MRD, and accordingly we can plan for some adjuvant treatment. So now comparison of tissue and liquid biopsy, if we do, so it may look busy slide, but it is very important. So I will go one by one for each and every point. So first of all, for sample acquisition. So for tumor tissue sample acquisition, we have to go for some invasive surgical procedure to obtain tumor tissue. It may be true cut biopsy, but it may be bronchoscopy guided biopsy and all. But for liquid biopsy, just simple blood draw is sufficient, and that is also only 10 ml required. So for if we talk about repeat sampling, because if we are using this test for monitoring purpose, for treatment response purpose, for MRD purpose, then maybe we require this sampling again and again. So serial testing is very challenging if we want biopsy again and again, patient and associated risk also regarding pneumothorax, infection, hemothorax and all. On the other hand, because of the minimally invasive procedure like liquid biopsy, just drawing some blood, we can do this test on serial basis to monitor our treatment. There is clear-cut correlation of histology and cellular phenotype that is possible, but if we see liquid biopsy also, direct correlation between ctDNA result and histology, although not possible, but it is more reflective of tumor genomic landscape. Regarding sensitivity of assay, so lower tumor cell content acceptable with sensitive techniques, but very sensitive methods required for ctDNA. It may comprise even less than 0.1% of ctDNA. So it is more sensitive. Regarding analytical standardization, for tumor tissue, it uses existing validated tumor processing and handling procedure, while for liquid biopsy, standard for analytical performance characteristic of ctDNA have not been established till now. That's why it is not very rampant test and easily available test. As such, there is no guideline exist regarding the recommended performance characteristic of liquid biopsy at present. So substantial evidence of initial targeted treatment selection and subsequent treatment after targetable treatment failure all are mainly based on the tumor tissue sample. About liquid biopsy, there is less evidence for clinical utility, but increasing evidence day by day with for initial targeted treatment selection and subsequent treatment. So multiple genes are involved in the NSCLC. So, but we can't order different tests like sequentially for each and every mutation. Single gene reflex testing or multiple gene testing by NGS, if we compare, then multiple gene testing is clinically feasible. We can't go sequentially. First we will do for CGFR, then for ALK, then for NTRK, then for other genes sequentially. That is not feasible for patient. We should order multiple gene testing by NGS upfront, and whatever mutation we will get, then accordingly we can plan the management. So what are the different advantages of NGS? NGS has a number of advantages over the single gene test. As the number of clinically actionable biomarkers has increased, the ability to evaluate all known molecular alterations in single test has given NGS as a major advantage. So obviously, if we go back to maybe 5 years, 7 years back, then we usually try to find only EGFR or ALK. Then we may go for single gene test, because but now as we have seen, more than around 50% patients have some type of driver mutation, and there are a number of different driver mutation for which we can give some targetable to enumerate it, at least 10 to 15. So it is not possible to go for single gene testing for each and every mutation sequentially. So if one or few molecular markers are needed, then higher cost and longer turnaround time will be there. Otherwise, if we go for like NGS upfront, that it decreases cost also. So if many molecular markers are needed, then via NGS it reduces cost, shortened turnaround time, lower tissue requirement, and single gene assay is required. So for benefit of NGS versus single gene test is it detects broad range of molecular alteration in a single sample. It may identify new markers that could offer additional treatment option for a patient or provide information to help with the development of new or more effective treatment. But what is the problem with the NGS? Because of the high complexity and of workflow, it requires experienced personnel only. It is not a test that can be done in each and every lab. Advancement in the field of NGS are evolving rapidly, and patient and clinical community must receive sufficient education in this area to more generation of this test. So different technique which have been used frequently for mutation detection. So it may be single gene assays, Sanger sequencing, pyrosequencing, allele specific PCR, single base extraction. It may be gene panel assay like next generation sequencing, hybrid capture sequencing, or FISH, fluorescence based method like FISH. So we can see here that most of the variants can be found with the single or NGS order. Now, if we mainly focus on the EGFR mutation, because this is the most common mutation which at present we can target. So for EGFR mutation testing, sample type should be either FFP section, fresh, frozen, or alcoholic specimen. It can be used for PCR based assay. In cytology sample also, in cell blocks, we can prefer this test over smears, but there may be some discordance between EGFR mutation status in primary tumor and corresponding metastatic site. Although it is very rare, but it may be. Nowadays, even in the adjuvant setting, there is clear-cut guideline that we should check for EGFR testing. We should consider adding molecular testing for EGFR to be performed on the diagnostic biopsy or a post-surgical specimen to ensure that EGFR mutation is there or not, to confirm our adjuvant treatment decision. Because in a stage of 1B to 3A, in adjuvant setting, if EGFR mutation is there, osimertinib has been approved for this for the at least for 1 year. Here also advantage of NGS over PCR is there. One study showed that 48% of EGFR exon 20 insertion mutation have been identified by NGS, but they have been missed by PCR. Out of 17 most common EGFR exon 20 insertion mutation, only 4 can be identified via PCR. So many patients, if we go only for PCR, not NGS, we may skip, we may lose, and it will be difficult for future reference if we do later NGS and then we'll found that mutation. So it will be a big soup for us. Regarding ALK realignment, so in most cases ALK is done by ISC because it is very high turnover test. Maybe in another next day we can check, we can be informed that ALK is there or not, ALK realignment is there or not. But and on the other hand, false positive rate is only 0.1% with FISH, so ISC is less expensive, hence more widely adopted. Regarding ROS1 realignment test, there is some algorithm for predictive genetic testing of ROS1, and routine practice is that first of all, in an NSCLC patient, we should go for EGFR or KRAS testing, and ALK testing is side by side ROS1 testing. So ROS1 can be tested via ISC. If by ISC is positive, then reconfirmation by a single second method via FISH should be done. If ISC is negative, then no need to do further testing. But if we can go for FISH also. Similarly, if FISH positive, then we should confirm it by ISC. If negative, then no need. So detection of elevated ROS1 protein levels by immunohistochemistry may provide cost-effective screening prior to confirmative FISH testing. Regarding RAS testing, KRAS testing, RAS sends activity signaling to a number of cellular pathways involved in cell proliferation and survival. So there are some KRAS mutation which are mutually exclusive with EGFR and ALK mutation, and it accounts for nearly 30% of the lung adenocarcinoma. It is the most common mutation of these arise from codon 12 and 13, with the G12C variant found in 13% of the patient with lung adenocarcinoma, predicting poor prognosis versus wild type KRAS. To detect these KRAS mutations, single gene KRAS G12C testing is, although not currently recommended, but and should only be performed as part of multi-gene NGS testing. So at present, commercially available or FDA approved drug TKI for KRAS mutation is not available, but studies are ongoing. So identification targeted therapy for patients with KRAS mutation has been hindered by the protein structural biology, which has no binding pocket large enough for the therapeutic agents. But still, sotorasib is currently approved for patients with NSCLC, and trial of adagrasib has shown potential to early phase 2-3 studies. Acquired resistance to this therapy have been observed, although specific resistance mechanisms are not well understood till now. Regarding BRAF mutation, so in this RAF kinase, it is involved in the regulating of cell proliferation and survival of facilitating signal transmission between the cell surface and nucleus. This BRAF V600E mutation is present in more than 50% of BRAF mutation cases and is thought to be more prevalent in smokers. Non V600E mutation also are there, like V600K and G469A, although it is very less prevalent, occur in only 17% of patients with BRAF mutation. So overall, BRAF mutation occur in 1 to 5% of the NSCLC patients, and especially in adenocarcinoma. So BRAF mutation can be targeted with BRAF inhibitors, and addition of MEK inhibitor can also block one possible resistance mechanism of the BRAF inhibitor. Currently approved therapies for BRAF V600E mutation is dabrafenib and trametinib combination. Resistance generally develop via pathways that bypass RAF, such as redirection of the cell signaling via the downstream MEK1 or 2 kinase. Next is MET. So c-MET receptor tyrosine kinase and MET exon 14 skipping mutation in NSCLC have been seen in 1 or 2% patient. It is a normal role in embryogenesis, but in cancer, MET exon 14 skipping mutation cause in-frame deletion of the juxtamembrane domain, resulting in increased stability and consecutive kinase activation. So majority of these mutations, skipping mutation, can be detected via DNA NGS, but increased sensitivity with RNA NGS. So for MET exon mutation testing, ISC and FISH are not recommended. PCR DNA testing can be done, but it is design dependent, and for RNA it is technical consideration. So for MET, only NGS is the option. RET receptor tyrosine kinase and RET fusion in NSCLC, normal role in neuronal genitourinary development. In cancer patient, RET gene rearrangement give rise to chimeric cytosolic proteins with constitutively active RET kinase domain. The majority of the RET fusion can be detected by DNA and DNA NGS only, but increased sensitivity with RNA NGS also there. So here also for RET fusion detection, ISC has potential local implementation, but significant false negative results are there. Similarly for FISH, so because of that, ISC and FISH are not recommended. DNA NGS and RNA NGS should be done. So majority of RET fusion can be detected by DNA NGS, but increased sensitivity with RNA NGS also is there. Coming to next, NTRK fusion testing. So we have option of ISC, RNA or DNA NGS, FISH and RT-PCR. By all of these we can detect NTRK. There are some advantage or disadvantage for all the different methods. Most sensitive out of all is RNA NGS, and although ISC is widely available, but that is fast, but still there is some problems. So choice of assay will depend on the institution, resources and clinical context. Reflexing to NGS versus ISC reasonable for NSCLC due to low prevalence of NTRK fusion. So important to qualify negative results and limitation of sample or testing. So regarding NTRK, ISC gives rapid results. It detects transcribed and translated events only. So low cost as a single agent, single test, widely available. FISH also is very rapid. NGS is potential for multiplex testing, less depletion of tissue, fusion partner and position are defined, and NGS are the most sensitive. Coming to next, it is also very important mutation, that is HER2 mutation in NSCLC. So B2 present in 3 to 5% of NSCLC adenocarcinoma, mostly exon 20 in frame insertion is there. It is also mutually exclusive with other mutations, mostly seen in never smoker. If that is present, then it is associated with worse overall survival. But if we target these HER2 mutation and amplification via targeted therapy like now present ADC, transdermal detection, then this survival can be improved. ISC used to assess HER2 expression seen in 59% of the NSCLC patients, but 2 to 3% only in the 2 to 3 plus only in the 30%. So we have discussed different methods how these tests should be done, which different mutation can be checked and should be checked. So this is the according to guidelines. This is the flow chart for this is a treatment paradigm for the molecular biomarker positive advanced NSCLC in 2022. If EGFR is there, then third generation TKI is the preferred one, but in some resource constraint settings, we can go for first generation TKI also. And if exon 20 insertion is there, then amivantamab or mobocertinib should be prescribed. If uncommon mutations, then afatinib or sunitinib is preferred. For ALK, either of the three generation TKI, but most commonly and most important nowadays lorlatinib. So ROS1, crizotinib or entrectinib. For BRAF mutation, durvalumab and trametinib combination. For NTRK, entrectinib or larotrectinib. For RET, selpercatinib or pralsetinib. For metaxone, capmatinib or tepotinib or KRAS, sotorasib. So all these drugs are although FDA approved, but not all drugs are available in India at present. But most common mutation EGFR and ALK we can target. So we should follow treatment option for adenocarcinoma, squamous cell carcinoma without actionable biomarkers. If these biomarkers are not there, then we can offer chemotherapy plus minus immunotherapy. Regarding PD-L1 antibody clones, so ISC platform and scoring system in lung cancer. So we all know that there are 2-3 platforms like 22C3, CP263, SP142 and 28A. Most common one out of all is TACO method, that is 22C3. It is used in the pembrolizumab trials. So companion diagnostic type is there, and here in this scoring system is PD-L1 positive if tumor proportion score is more than 1% or more than 50%. So plus positive only or high. Regarding SP263, platform is Ventana, same for SP142. For SP263 have been tried for most of the Infinity trials, durvalumab trials, SP142 for Tecentriq atezolizumab trials. So PD-L1 high here with SP263, they give if tumor proportion score is more than 25%. For SP142, if PD-L1 positive, TC is more than 1% or high, it is more than 50%. These are the different antibody used. So SP263 is 22C3, 28 and SP142. The different scoring system is adopted depending on the antibody used to detect PD-L1. So it should be clearly mentioned in the report which platform have been used, and clinicians can enlighten the pathologist or molecular biologist to use appropriate platform, and they may write on the paper what drug they are planning to give. Accordingly, they can use different platforms. So PD-L1 is sole current biomarker able to guide immunotherapy. It is although imperfect, PD-L1 negative tumor can still respond. Mostly have added chemotherapy, which may be synergistic effect or only because of the chemotherapy. It is still unknown. Other are MSI high or tumor mutation burden. So former marker for response, but not very routinely used, because most of the time we have seen if we use immunotherapy on the basis of TMB only, so those are not very good results. Conflicting correlation with survival in checkmate studies also. Although for lung, especially MSI testing is not used, but as such, as per recommendation, any soil immunancy we can try, we can check MSI, and if it is high, then we can offer pembrolizumab. LAG3, it is possibly related to resistance to immunotherapy being studied, not recommended at time. So now to conclude, and some key take-home messages regarding these biomarker testing. So biomarker testing in SCLC has evolved from a single gene test to multiplex testing. Multidisciplinary meetings help in better understanding of sample and test requirements. These samples should contain adequate tumor content, at least 10%, to prevent delay in the processing. Ideal TAT for NGS is at least 2 weeks, and some laboratory may take 3 to 4 weeks, but most of the time it may be because of the sample processing, and maybe sample is going to for a distant site or lab. At least on average 10 working days are sufficient. High throughput platforms such as NGS can be used to screen several genes at a time to provide results within its estimated time. So all these oncogenic targets and testing methodologies we have discussed in today's presentation, and clinical guidelines strongly recommend broad molecular profiling to identify rare driver mutation for which effective drugs may be available, or to appropriately counsel patients about available clinical trials. Broad molecular profiling is a key component for the improvement in the care of the patient with NSCLC. So with this, thank you. House is open for any query. You may unmute yourself or may write in the chat box if any query.
Thank you so much, Varun sir. Uh, we'd like to invite next Dr. Dharmista Basu. This session is sponsored by AstraZeneca. Over to you, Ms. Dr. Dharmista Basu.
Am I audible and visible?
Yes, ma'am, you are audible.
So, good evening to one and all. Today's agenda of meet that has been assigned to me is the real world data that is associated with osimertinib in the management of EGFR mutant NSCLC. As we know that the standard of care for NSCLC in the front line is osimertinib. As compared with cytotoxic therapy, it was first proven in the AURA trials in the subsequent line, and eventually the data that changed the standard of care in the front line was the FLORA trial, in which osimertinib came up with an unprecedented PFS benefit of 18.9 months versus 10 months, with a hazard ratio of 0.46, and also a statistically significant overall survival 38.6 versus 31.8 months. This is the best treatment option that is available for untreated EGFR mutant NSCLC in the advanced stage. To discuss where this data comes from, FLORA was a double-blinded study with a key inclusion criteria of 18 years and above, good WHO performance status, EGFR del 19 or L858R mutant, stable CNS metastasis allowed, and no prior systemic therapy or EGFR-based TKI therapy taken. Stratified by mutation status and race, the patients were assigned to either osimertinib arm or a comparator EGFR TKI arm. The final OS analysis was planned after approximately 318 events. As we can see that the baseline characteristics of both the groups were more or less well matched, including the ratios of EGFR del 19 versus L858R, the adenocarcinoma versus others, and also CNS metastasis that were admitted at study entry. Here we can see that the well-known data of PFS of 18.9 months versus 10.2 months, giving a significant edge to osimertinib with a hazard ratio of 0.46, with a forest plot showing this PFS benefit to be seen across all the various subgroups that were tested. Most importantly, the groups that deserve mention is the CNS metastasis at trial entry, EGFR del 19 mutant versus EGFR L858R, and both these subgroups were showing significant PFS improvement. The final OS analysis gave us osimertinib OS of 38.6 months with a comparator EGFR TKI arm OS of 31.8 months with a hazard ratio of 0.79. This showed that FLORA enforced osimertinib as a standard of care for the first-line treatment of patients with EGFR mutant advanced NSCLC. The statistically reinforced OS as well as PFS benefit was proven by the study. So as we can see, not only though this is an older version of the slides, even in the latest 2025 versions, EGFR mutant NSCLCs, the preferred frontline therapy is osimertinib. So here is to here we discuss some of the real world studies that have reinforced our knowledge of osimertinib usage, taking it out of the flora and bringing it out into our real world clinic practice. The flower study, first line osimertinib patients in EGFR mutant advanced non-small cell lung cancer. So this is the data that we have already discussed, so not reiterating again. The flower study had a baseline age group of median of 68 years, and around 30% of the patients had brain metastasis at diagnosis, which is more or less matching other studies that were done in the same setting, with around 23.8% of the patients having stage 4A and 71% presenting in stage 4B disease. And majority of the patients, that is 95.2% of the patients, were adenocarcinomas, though there are other histopathological subtypes also included, that is squamous and adenosquamous. The inclusion criteria was age more than 18 years, histopathologically and cytologically confirmed diagnosis of NSCLC with one or more EGFR mutation in the exon 18 to 21, having a locally advanced recurrent or metastatic NSCLC, who is eligible to receive first-line treatment with a third-generation EGFR TKI. So the study endpoints were a little different from our conventional ones. Here they use the endpoint of time to discontinuation of treatment, which has been explored as a pragmatic real-world endpoint to assess effectiveness of anti-cancer therapy in NSCLC, which reflects the common practice to continue EGFR directed TKIs in patients who have a resist progression, but they have an oligometastatic disease. So this oligoprogressive site is usually dealt with some local therapy, but the treatment continues to be the same EGFR TKI. So instead of using a PFS, we use a time to discontinuation of treatment. They have also assessed the rate of treatment-related adverse effects and the rate of dose reductions and temporary or definitive treatment interruptions. Diagnostic to therapeutic pathway has been assessed in the study as a secondary endpoint, which is defined as a time frame between diagnostic biopsy, histopathological report, the proportion of patients who underwent loco-regional treatment, time and frequency of free biopsies performed at progression. The primary assessment for effectiveness, patients with poor PS, comorbidities, rare EGFR mutations, active brain metastasis were included in this study, but these patients were not included in the actual FLORA trial. So this trial couldn't answer the real world ground realities when it came to treating patients with these conditions. Outcomes were similar to published data, thus adding consistency to osimertinib efficacy. There were no differences in the PFS, time to treatment discontinuation, OS, in the elderly patients as well, patients with comorbidity and less common EGFR mutations. So coming to the effectiveness curves, the time to treatment discontinuation in the median was about 25.3 months. So considering a PFS benefit in the osimertinib arm of FLORA, where the PFS is around 18.9 months, considering a lot of people have oligoprogression, here time to discontinuation comes out to be about 25.3 months in a real study. This time to discontinuation is actually much better when there are no symptoms and if the sites of metastasis are less than 3. Here the median had not even been reached, whereas the time to discontinuation in patients who is symptomatic at diagnosis with a PFS of 18.8 months, and it is around 21.4 months in the patients who have 3 or more sites of disease metastasis. Patients, here we can see that time to treatment duration appears to be a much more suitable endpoint to evaluate treatment outcomes in the real world data. This is something that we have already discussed, that the FLORA trials PFS and our treatment time to treatment discontinuation are totally very different values, and time to treatment discontinuation appears to be much longer than the actual PFS offered in the FLORA. So here we can see that the hazard ratio of PFS in the univariate and multivariate analysis and the hazard ratio for OS in the univariate and multivariate analysis has shown that symptoms being present at diagnosis is quite predictive of having a poorer time to treatment discontinuation. And same is true for the OS univariate and multivariate analysis for the patients who had 3 or more metastatic sites. Here we find that PFS and OS and also the time to treatment discontinuation analysis are found to be statistically significantly showing a worse outcome. And so is presence of brain metastasis at diagnosis. So the real world diagnostic therapeutic pathway, essential element of evidence-based medicine, which helps the decision, the patient in the clinician in making critical decisions for the patient. Among the patients experiencing a PD, 47.7% patients underwent a rebiopsy at progression. In around majority of the cases of 66.7%, it was a tissue rebiopsy, whereas in around 28.6%, it was actually liquid biopsy. The molecular analysis that was performed in around 61.9% of the samples showed that there were druggable resistance mechanisms where we had MET amplification as the most common, MET amplification and EGFR amplification, and HER2 amplification to follow. As we know that understanding osimertinib side effects, it is mostly a very well-tolerated drug, but we do need to understand the risks associated with ILD, diarrhea, and venous thromboembolism that are associated with this group of medicines. 87% of the patients experience some or the other grade of adverse events. Venous thromboembolism was surprisingly the most common. This should be kept in mind in the real world data. 7.9% of the patients experienced venous thromboembolism. Grade 3 pulmonary embolism accounted for 2% of the patients receiving osimertinib-based treatment. There is no difference in the rate of venous thromboembolism as per age, PS, comorbidity, or tumor load, as can be demonstrated in this study, in this chart. So we can say that in the real world also, osimertinib is living up to its safety and efficacy in terms of its time to treatment discontinuation, its efficacy in terms of tolerance, and also the adverse effect profile. Coming to the next study in line, which is osimertinib as first-line treatment for advanced EGFR mutant non-small cell lung cancer in the real-world setting, OSIFACT. So this is the data that we already know. So this current study investigated the difference in efficacy with patient background and the safety of first-line osimertinib treatment in the real-world scenario. Inclusion criteria for the study was advanced EGFR mutant NSCLC with osimertinib coming as the initial treatment. The patients concurrently using other anti-cancer agents or undergoing thoracic radiotherapy, undergoing post-operative adjuvant chemotherapy, or receiving osimertinib as second line were excluded. Baseline patient characteristics show similar parameters as compared to the FLORA trial and also as compared to the FLOWER trial that we have discussed earlier. 98.3% were adenocarcinomas, though squamous cell and non-small cell carcinomas were also included. Well-balanced distribution of patients between L858R and DEL19 mutation. Around 66% of the patients are stage 4, and brain metastasis is present in about 31% of the patients, where 6.1% were symptomatic at baseline. The study's primary endpoint was PFS. Time to treatment failure has been taken as a secondary endpoint. The median PFS as per the study was around 20.5 months, which is a similar value as compared to that provided by FLORA. The parameters that were significantly associated with poorer PFS were male gender, presence of malignant effusions, detect presence of liver metastasis and advanced unresectable diseases at presentation. This is corroborated. The primary endpoint PFS analysis, the hazard ratios that have been detected to be the worst in the male gender, presence of malignant effusions, presence of liver metastasis, presence of advanced unresectable disease at presentation. The discontinuation of treatment profile in 44.3%, the treatment was discontinued in view of disease progression. Among the side effects that led to discontinuation of treatment in 16% of the cases, the most common were to be seen as anorexia and skin disorders. As we know, there could be risk of rashes or paronychia with the use of osimertinib. And other causes that have been evaluated are progression of other diseases, did not follow up, patient's request, doctor's judgment, as seen in 14.2% of the cases, and pneumonitis, which is seen in around 25.6% of these cases. So concerning rates of pneumonitis have been referred over here, as seen in the previous chart as well, and also seen over here in this table. Pneumonitis, all grades have been presented to be around 12.8%, and grade 3 or more has been seen in 4.5%, leading to death in around 4 of the cases. Reduced ejection fraction, which is one of the theoretically important side effects of prolonged osimertinib use. Grade 3 or more rates of heart failure is hardly 0.9%, though it is a clinically significant side effect to watch out for. Concluding from the study, overall response rate 76.2%, disease control rate is an exceptional 94.1%. PFS is better with osimertinib than with conventional EGFR TKIs, and this improvement is irrespective of PDL1 expression. Median time to treatment failure was 19.1 months. Onset of AEs are seen mainly at around 56 days. Pneumonitis of all grades, including in all 69 patients, was seen in around 12.8%. Grade 3 or higher was seen in 4.5%. Fatal pneumonitis in around 0.7%. PFS after first-line osimertinib in real practice, in conclusion, is found to be favorable. In this study particularly, the rate of discontinuation has been exceptionally high, especially because of pneumonitis. And why is it so? And what are the predisposing factors to osimertinib-associated pneumonitis requires further investigation. A real-world study of patients with EGFR-mutated, locally advanced metastatic NSCLC treated with frontline osimertinib. So discussing the background, as we already know that the baseline data comes from the FLORA study. This study reported the demographic and clinical characteristics of real-world time to new treatment or death and the real-world time to discontinuation of treatment in patients who received first-line osimertinib in EGFR mutant advanced NSCLC in the United States. This has been a global observational prospective cohort study. It is ongoing in the US, Europe, and Asia and involves the analysis of registry, electronic health records from country-specific data sources. This US sub-analysis includes data coming from the nationwide Flatiron Health Electronic Data Record System. It is comprised of de-identified patient-level structured and unstructured data. During the study period, de-identified data originated from approximately 280 US cancer clinics, that is around 800 sites of care. For this interim sub-analysis, data was collected till June 30th of 2020. This study is ongoing and follow-up is planned in June of 2023. Possibly we are awaiting the latest data from this follow-up. The patient inclusion criteria: 18 years or more at the time of diagnosis, stage 3B to 4 NSCLC, EGFR mutated documentation, initiation of first-line osimertinib monotherapy between April 1st, 2018 to March 31st, 2020. So this is the study design. where we take day 0 to be the index day of initiation of first-line osimertinib. This corresponds with April 1st of 2018. And the follow-up and assessment outcome window, the patient identification end date started till March 31st, 2020. The interim data analysis date is June 30th of 2020, and it was planned to continue till June of 2023. The baseline clinical and demographic characteristic treatment patterns were summarized using descriptive statistics. Kaplan-Meier statistics were used for TT, NTT, and TTD. And Cox proportional hazard models were used to see the association between covariates and clinical outcomes. So here we can see that the age distribution as pretty similar to the OSIFACT and the FLOWER trial. The median age at diagnosis is around 70. Females being more common, around 70% as opposed to around 30 being male. Whites are the predominant population, with 80% belonging to stage 4, which is pretty similar to the baseline demographic characteristic to the previous studies. Non-squamous histology is 97.8%, which was around 98% adenocarcinomas in the previous 2 studies. They have documented around 43.2% of the patients to be smokers in the study. And baseline Charleston comorbidity index, number of metastatic sites, presence or absence of liver and brain metastasis has also been noted. And here we see that presence of brain metastasis is seen in around 33.3%, which is similar to the previous 2 studies. EGFR mutation positive patients, here we can see that DEL19 mutation alone was present in 51.1. I'm sorry, am I audible?
Yes, ma'am, you are.
Can the organizers please project my slides? We are at treatment sequencing.
Sure.
This is slide number 41, please.
Okay, ma'am.
Slide number 41, treatment sequencing. Yes, that would be it. So as we can see here that the treatment sequencing shows that 58% patients remained on osimertinib therapy and were eventually lost to follow-up. 18.8% patients received second-line therapies. These second-line therapies could be PD1 or PD-L1 based combination or monotherapies. They could be EGFR TKI based combinations or monotherapies, chemotherapy based combinations, or clinical study based therapies. A minority of the patients also received single agent chemotherapy, anti-VEGF based therapies. 18.4% patients died while on first-line osimertinib based therapy, and the discontinuation rate was around 4.7%. The median follow-up time was 9.6 months, and the median real-world time to new treatment or discontinuation was 17.9 months, uh, similar to the PFS that was offered by the Flora trial, with a 95% confidence interval of 16 to 23.6. 18.4% died while on frontline therapy, and 18.8% switched to second-line treatment, the combinations of which we have already discussed. In this multivariate analysis, this advanced stage at initial diagnosis, smoker status, a baseline Charleston's comorbidity index of 3 or more, EGFR, uncommon EGFR mutations at diagnosis, or 4 or more metastatic sites were associated with a worst uh, time to new treatment initiation or treatment discontinuation uh, durations. The median time to treatment discontinuation was 17.2 months, 18.4% deaths, 18.8% switching to second line, and 4.7% discontinued treatment. Please switch to the next slides. The one after that, please. So as we have discussed, the stage at initial diagnosis, the smoker status, CCI, and the EGFR uncommon mutation at diagnosis, and number of metastatic sites being 4 or more, is associated with a worse real-world time to new treatment or discontinuation of treatment times. Next slide. The time to treatment discontinuation is 17.2 months. As we have already discussed, 18.4 people percent of the people died while on frontline therapy, and 18.8% of the patients switched over to second line. Next slide. The multivariate analysis showed that the real world time to treatment discontinuation were associated with worse outcomes if the baseline Charleston comorbidity index was 3 or more, 2 or more ECOG performance status, uncommon EGFR mutations at diagnosis, 4 or more metastatic sites, and evidence of liver metastasis at diagnosis. Next slide. The take-home messages from the 3 studies that we have seen over here, that frontline osimertinib is the standard of care that should be used in the patients with advanced EGFR mutant NSCLC. The data is corroborated now by real-world studies. The interim real-world time to new treatment or treatment discontinuation and the real-world time to discontinuation supports the effectiveness of osimertinib in the real-world population. These studies will evaluate the longer outcomes in the final analysis. Next slide. Thank you.
Thank you, ma'am, for your talk. Would like to invite Mr. Dr. Varun Goel for that talk. This session is sponsored by AstraZeneca. Over to Dr. Varun Goel.
Yes, just let me share my slides. 1 minute.
Sure.
So my slides are visible, and
Yes, it is.
just so next topic, and today's last topic. It is regarding reimagining CNS mutation, and regarding these EGFR mutation in advanced NSCLC patient, how treatment compare, what should be our approach to manage these patients efficiently. So this we have already discussed about the NSCLC incidence. It is most common cancer, like second most common cancer in men. Overall, it is fourth most common cancer, highly prevalent cancer, and associated with high mortality. So there is still high unmet need. So one important point to be noted that in patient with lung cancer, they have highest rate of identified brain mets either upfront or during the course of the treatment. And these brain mets incidents are more pronounced in EGFR mutation positive patients. So if we follow these patients at final follow-up, up to 44% patient of EGFR mutation NSCLC will have brain mets compared to 22% patients who are wild type EGFR. And out of all, leptomeningeal enhancement are associated with poor prognosis when not treated. If once leptomeningeal enhancement happens because of the cancer, then survival is 4 to 6 weeks only. These leptomeningeal metastases may be more frequent in patients with EGFR mutation positive versus wild type. Approximately 10 to 20% of the NSCLC patients who have brain mets at the time of diagnosis, and approximately 40% patients will develop brain mets during the course of the treatment. So, in a metastatic lung cancer patient, brain mets happens in significant number of patients. Other site of metastasis are bone, congenital lung, liver, and adrenal gland. But with brain mets, it is one of the common site which associated with decline in the quality of life. So, patient with a single brain mets experience the greatest decline in the quality of life compared to the other site mets. So regarding these brain mets, we already know that brain is a sensory site for invading metastatic tumor cells because it is protected by blood-brain barrier. Up to 40% of patients of NSCLC with EGFR mutation will develop brain mets. So different EGFR TKIs are also substrates for human blood-brain barrier efflux transporters to varying degree. So this influences the distribution of these compounds in the brain at equilibrium. Hence, it is very important that out of all EGFR TKI available to us, maybe first, second, or third generation TKI, we should use that drug which have good brain exposure to achieve intracranial efficacy. So osimertinib have differentially penetrates intact blood-brain barrier in monkey brains in preclinical studies, and has demonstrated higher mouse brain concentration than other TKIs. So these studies on animals show that osimertinib has highest brain penetration out of all available EGFR TKI which have been studied till now. This drug caused tumor regression in EGFR mutation brain mets patient in a mouse xenograft model. And osimertinib was homogeneously distributed in all regions of brain in healthy volunteers. So it is not only animal studies, even in preclinical healthy volunteer studies, this drug have been shown to be distributed homogeneously in all regions of the brain. So what about this drug? This is a third generation EGFR TKI. It binds irreversibly to clinically relevant mutant EGFR kinase that may be exon 19 or 21. Even in T70M mutation, also this drug is responsive. So it prolonged PFS and OS related to first generation EGFR TKI. It is the first drug with the FLORA trial which have shown OS benefit in this setting. It exhibited anti-tumor effect in patients with NSCLC which are harboring various EGFR mutation, either common or uncommon. It has associated with high blood-brain barrier penetrance and brain exposure related to other TKIs, which is very active against CNS mets, and it inhibits the growth of CNS mets in patients with EGFR mutation positive NSCLC. How does this efficacy of osimertinib if we want to compare with the first generation TKI? So if we see in the FLORA study, which is EGFR mutation metastatic NSCLC patient, osimertinib have been given as a first line. So out of all patients, majority of the patient has metastatic disease, with 35% patient having visceral mets and 21% patient having CNS mets. So if we see here the results of the FLORA study, PFS, which is a direct measure of the drug benefit, in patient with known or either treated stable CNS mets patient, median PFS was 15.2 months with osimertinib, while it is 9.6 months with first generation TKI, either gefitinib or erlotinib. So clearly there is statistically significant improvement in the CNS PFS. It ratio is 0.47. So osimertinib had significantly longer OS than compared to EGFR TKI. And if we see at the landmark of 2 years, 74% of osimertinib patients were still doing well and surviving. If we compare with the comparative EGFR TKI, that is 59% only. At 36 months, 54% patients still surviving, while with the first generation TKI, only 44% patients were surviving. So CNS progression events occur in 6% of patients in osimertinib arm, while 15% of patients in first generation TKI arm. It is a FLORA trial which have demonstrated that osimertinib has a superior systemic PFS benefit regardless of the CNS disease at study entry versus EGFR TKI first generation. So this term, intracranial CNS PFS, it is a full CNS full analysis set. So we can see here clearly in this Kaplan-Meier plot that with osimertinib, median CNS PFS not reached versus with first generation TKI it is 13.9. Both the graphs are well distant to each other, there is no crossing over, and this benefit in the graphs happens from the very beginning. The ratio is 0.48, median follow-up of 12.4 months and 7 months have been done in these patients, and CNS PFS was statistically significant with osimertinib versus comparator. So CNS progression by independent committee review board have been occurred in 20% in osimertinib arm while 39% in the first generation TKI. No only treats but also, so overall we may say, so if patient doesn't have upfront CNS mets, then there is less occurrence of CNS mets if we treat with osimertinib. And if patient already have CNS mets, stable, non-symptomatic, then these patients CNS mets may decrease, may go away radiologically, and patient remain asymptomatic for a longer time. So patient with or without CNS mets at the trial entry, investigators assessed CNS progression events were observed in 6% and 16% if we compare osimertinib versus first generation TKI. First line osimertinib may delay the need of subsequent therapies, and 28% versus 9% patient continue to receive first line trial drug at even after 36 months. So this is unheard of earlier. And in a patient with CNS mets earlier, before the advent of these drugs, and if patient is not harboring any driver mutation, then median OS is around 6 to 8 months only. But now with these drugs, more than 50% patients are still surviving even after 3 years of follow-up of the treatment. So what some real world evidence we talk about regarding this setting. So rapid intracranial response to osimertinib without radiotherapy in a NSCLC patient harboring EGFR T790 mutation. 2 case reports have been published, and in this case one case is 67-year-old female in which EGFR L858R mutation was there. So initially gefitinib was given allotinib as a 5th line chemotherapy, but later osimertinib was started even after multiple line of therapy. On day 5 of measure of osimertinib, chest X-ray revealed shrinkage of right pulmonary nodule and complete remission of the brain mets even on day 13. So this patient underwent right middle lobe resection of the lung before early stage 9 years back, but multiple nodules emerged in both lungs 7 years ago. On mutation testing, it is EGFR L858R mutation on exon 21. First, gefitinib was administered, which was patient take for around 3 years. After that, different chemotherapy drugs like PEMCAB and tegaparuresil with BEV and docetaxel, later allotinib again was given, but all these drugs failed. Mainly allotinib failed within 3.5 months. Then vinorelbine was tried. Then patient again further progress and developed thoracolumbar bone mets. Radiotherapy was given for that, for pain and palliation. And later, as a desperation, because now osimertinib was available commercially, osimertinib was given to this patient, and this patient have shown surprisingly very great results in this patient. Similarly, second patient, it is 76-year-old male, so these are geriatric population patients, maybe associated with significant comorbidities, various different concomitant medications already going on. Even then, we can give these drugs. So in this 76-year-old male, significant smoking history, he underwent right upper lobe resection 10 years ago, found to have EGFR exon 19 mutation. That time adjuvant osimertinib was not a dictum, so he was put on follow-up. After around 3.5 years, he developed multiple bone mets. Initially, gefitinib was given, which he received for around 4.5 years. On progression, apatinib was given, but with the PAMCAV and BEV, but and later different other chemotherapy was also given, but there is no response. In after second or third line, PFS is very less. Last attempt osimertinib was given as a fifth line, and when PS was 2. On day 10, brain CT revealed remission of single brain met. On day 14, decrease in the pleural effusion and shrinkage of pulmonary nodules. And after a month, chest CT revealed shrinkage of multiple lung mets. His PS improved to 1, and effusion tapping was not required later. Overall, very good result. Another case of complete remission of multiple brain mets in a patient with EGFR mutation patients have been published. Even here, radiotherapy was not given. So almost similar finding, similar results, very good CNS response. So with the advent of these drugs, with the availability of these drugs, and now with our growing experience and evidence, now if patients are asymptomatic, even in slight symptomatic patient, we don't try to give, we try to avoid radiation in these patients. Just give these targetable TKI, and results are there. So another cohort study in which this is retrospective cohort study. So around 36 patients have been taken with EGFR mutation positive LHCLC patient and given osimertinib. This study was in between from 2014 to 22. So here also almost similar observation. 36 patients who had median interval from brain mets diagnosis to first line osimertinib initiation is 25 days. In total, 136 previously untreated brain mets were tracked from baseline, and this reflected best objective response of 100%. So over 2-year-old survival is 80%. So based on all these real world evidence and FLORA trial results, different guidelines including NCCN, ESCO, ESMO, all have included uh, osimertinib as a preferred regime as a first line therapy, especially if exon 19 or 21 mutation is there. Even in uncommon mutation, this drug can be preferred. Even in CNS matched patient, this drug can be preferred. So with this, thank you. Any query you may ask, otherwise can be written in the chat box if any query. If no further question, then thank you once again all the audience and all the faculties which have given time for this meeting, and because of their efforts and time, this type of meeting is successful. Thank you once again all the audience. Thank you, Horizon, for seamless holding of this meeting. Thank you, AstraZeneca, for that sponsorship. So, good night, everyone. Thank you.
Thank, thank you everyone for joining this webinar. We'll see you again. Thank you. Good night.
Good night. Good night.
Technical team, please close the meeting.
Hello.
Yes, technical team.
Yes, ma'am.
Yes, please close the meeting.